Okay, guys, welcome to one more series of Iniss and Snippets. This is the fourth series and based on hypothermia and peripheral cold injuries. It's a 8-minute series, entire chapter in 8 minute series. I've told you how to study in my previous sessions. If you're going to subscribe, I'm going to give you more so that your Neet assess and Iniss, the starting 400 and the last 400 of Harrison is very important and it's going to get covered. Okay, coming to hypothermia, core body temperature below 95 or 95 Fahrenheit, 95 degrees Celsius. It can be accidental, it can be secondary hypothermia because of a systemic disorder. 4 questions were asked on cold this time, right? Causes again or the risk factors. What I would like to mention is this: elderly, neonates, occupational hypothermia, sports related, inadequate clothing, immersion, alcohol, anesthesia, antipsychotics, antidepressants, anxiolytics, benzodiazepines, neuromuscular blockers causing hypothermia, malnutrition, marasmus, and kwashiorkor, neurological, CVA, hypothalamic disorders, Parkinson's, spinal cord injury, and multisystemic involvement like sepsis, trauma, shock, organ failures, malignancies, burns, immobility or debilitation. These are very important, and this was asked. Neat. Diabetes, hypoglycemia, hypothyroidism, adrenal insufficiency, hypopituitarism. Remember that hypopituitarism secretes ACTH. If it is gone, there will be adrenal insufficiency. Also, thyroid for temperatures and BMR, hypoglycemia also associated with sepsis, right? Diabetes mellitus will cause increased glucose. So, increased glucose or decrease glucose both are associated with hypothermia, right? Neonates have higher rates of heat loss. This one you have to know. Dementic patients, also psychiatric patients, are also they also can develop this heat loss. So hypothermia there. And obese occupations, military history, hypothermic tragedies. So this time 2 questions were asked on Siachen glaciers. Ethanol, how it inhibits the thermogenesis, inhibits the gluconeogenesis, and impairs the judgment so that you won't go for heat exposures. Anesthesia also blocks the shivering, right? Adrenal insufficiency, susceptibility to hypothermia. All these things you have to know. And hypothalamus also, it's a key center, right? It's a posterior is a heat gain and anterior is a heat loss center. And this Shapiro's is a potential question whether this agenesis of corpus callosum. It is one of the cause of episodic hypothermia, just episodic hypothermia. Even spinal loss can also occur. Right? How the Shapiro causes is by profuse perspiration followed by rapid fall in temperature. Okay. Then even MI, low cardiac output, will cause hypothermia. All these things you have to know. Like burns also will cause peripheral vasodilatation, heat loss, and hypothermia. Psoriasis, erythrodermas, and skin diseases are a potential question for heat loss. Even organ failure, which I mentioned there. Autonomic pathways are lost in spinal injuries, which can cause hypothermia, right? So how heat loss? Last time I told the 5 mechanisms in the previous chapters, right? So anterior hypothalamus is the heat loss center, right? That causes hypothermia. Clinical presentation, obviously you would be knowing, and there is something called as mild, moderate, and severe. I'm just touching up as to what can be included and what cannot be, what will only be given. Mild, moderate, severe. Remember 32, 28, less than 28. These are the values that you have to know. Forget the Fahrenheit. If you want, you can know 95, 90, 83, right? In mild, these are the things that's going to happen. But in moderate, what you have to remember is that there is hyporeflexia, right? There will be coma in severe. This is what you have to know. And one more thing that I want to touch up is that the EEG abnormalities will occur even here because of impaired judgment, but mostly it occurs in cases of moderate, right? In moderate, there will be more EEG abnormalities. And where does the J wave start? is in the moderate. So most of the things that your answer would be a moderate. That's why I marked moderate in the first point. I have jotted down, and this is my analysis from the past 3 years, right? And you can watch gauge thing on me that this is what is going to come for your exam, right? When a patient comes in hypothermic state, and there is ECG showing flat, it is called cardiac arrest. Do you want to do CPR? Yes, you have to do CPR, right? You always have to do CPR, but there are reasons, like when there is a depression of the frozen chest is not possible, or lethal injuries are identified where you can't give CPR, or do not resuscitate status. In India, this doesn't hold. Remember that in the field, when the core body temperature is less than 28, CPR is really effective, and these patients will be having very high potassium levels because of cell lysis. But don't worry, don't correct it also. Immediately resuscitate by giving him the adequate rewarming, right? Give him the fluids, and then you see, then over 7 hours of cardiac arrest also there has been survival. So that is why we are telling the decision to terminate the resuscitation before rewarming the patient past 30T should be predicted. So once he reaches 33 degrees Celsius and there is still no signs of cardiac improvement, then stop CPR, right? Remember that don't correct anything. Even there will be severe acidosis with pH less than 6.5. Because of hypothermia, there will be coagulopathy also, right? You have to correct the precipitating cause, then you have to treat them. So how do you measure the core temperature? Is by the CBT. That's the core body temperature. That's the lower third of the esophagus is preferable. All these are in experimental settings. Patient will be always usually dead. Pulse undetectable in 99% of the patients. Pulse will be undetectable. Because of hypothermia, amplitude will also be very low, right? If you measure the end tidal CO2 and echocardiography, these are also very important, right? You also have to give supplemental oxygenation,